Good morning and welcome to Royal Roads University. I'm very glad that this day is here, and I'm well past my what were you thinking stage. I'm very glad that this has come together the way it has. Let me start and ask Ellen Cahoon, the senior dog here at the campus, president of the university, to come say a few words of welcome on the part of Royal Roads. Ellen?
Thanks, Roger, and I'd like to welcome you to Royal Roads for those who haven't been here before. This is a building that we're quite proud of, having opened earlier this spring, and this is a center, the Center on Dialogue, that hopefully for you will give us a sense of being able to have discussions and raise issues and create action. I want to thank Roger for his efforts in putting this together. Retired Rear Admiral Roger Gerard. I was getting up this morning and I heard him booming in the background on the radio, explaining a little bit about this course. It is his commitment and energy and vision to get this forum going. He is a graduate of our MA in Leadership program and an associate faculty member in our School of Peace and Conflict. We think this is a really important and timely topic. We believe that PTSD is an issue and an opportunity for us to engage in dialogue. We hope that today there will be a conversation and discussion involving experts on the disorder, both from the medical community and from the research community. Current members and former members of the Canadian Forces and community members who have been affected by the disorder, including family members, care providers and practitioners, people who also participate and understand the consequences and impact of this. I don't think that such a diverse group of people have been brought together in the Capital Regional District before, and it's come to have a conversation about what Professor Tim Black has said is the trauma-informed community of care. And I think that challenge and that responsibility has brought us here together. Royal Roads is proud of its connection with the military, both historical and present. We appreciate and recognize our origin as the Royal Naval College and the Royal Roads Military College, and now Royal Roads University. We have many of our graduates who have served our country and suffered from PTSD. We would like to provide them and be part of providing the support that they need. And this conference and this forum hopefully will do this. PTSD is not an issue or a challenge only faced by people in uniform. It's a challenge for our entire community. People affected by PTSD are victims and witnesses of trauma, members of the police force, emergency responders, care providers, humanitarian and disaster relief volunteers, workers who go overseas. There are a number of people who are participants and have experienced various aspects of PTSD. Royal Roads has a master's degree in human security and peace building, another master's degree in disaster and emergency management, and many of our graduates are in the midst of natural disasters and humanitarian crisis and see these things first on. We hope that through today's discussions there will be dialogue and an understanding of how to support those living with PTSD and better understand the disorder in our community. I want to thank the Royal Canadian Legion for its co-sponsoring of the event. I want to thank you for participating and invite you to be active participants in what we're going to do today. So thank you, welcome, and Roger, thank you for taking this initiative.
Thanks very much, Al. I'm going to start using the microphone, and that's because we have live feed, and I'll find out in a little while just how many folks are online watching this. You may be aware, some of you are, that we waitlisted. I had about 70 folks in the wings, most of whom I wasn't able to bring in. but we've got folks that I know of in Calgary and Kingston and back in Halifax aiming to log on. Alan alluded to the fact that this is a cooperative effort. The Legion was very much a part of putting this together, and I'll ask my good friend David Monroe to perhaps say a couple of words on behalf of the Legion this morning.
Thank you, Roger. We're pleased to be here. The Royal Canadian Legion, specifically the BC Yukon Command, has been supporting the PTSD clinic now for somewhere close to 14 years at UBC, and now, of course, with UVic here with Dr. Tim Black. I was one of the participants in the first PTSD clinic they had, and I can tell you that it made a significant difference in my life. I look around the room and I don't see any of my old bosses, so I can tell some stories about how I could, the effect that PTSD had on me in some of my work life. But the Legion has been very successful in promoting this, and the Dominion Command are now taking a look at it, and other people are taking a look and saying, yes, it is something that we can do. Marv Westwood, Tim Black had a wonderful program, and I know many of the comrades that have gone through this program are very thankful, and not just from ourselves, but I can tell you for sure from our family. So welcome, and on behalf of the Royal Canadian Legion, I hope you have a wonderful day. Thank you.
Cheers, Dave. Thank you. The genesis of this particular day, in fact, it's got multiple roots. Certainly my work with Legion and hanging around a little townhouse duplex not too far from here, known as Cockrell House, which is a site for veterans that have been homeless, got me thinking about the topic. Amongst my other hobbies, I do some work with the Coalition of Homelessness. And so my friend John Ducker and I belong to the management committee, and running into some of my neighbors in VHA, I once asked Kelly Reed, one of the senior mental health pros in VHA, so of the Pandora Street issue, how many of those folks, those really intransigent homeless that are a problem for the police, how many of them have PTSD? And he said half, and that's probably a low ball. And so Alan's point that this is not merely a military issue is tremendously valid to me. I'm ex-military, had a couple of really interesting non-vacations overseas, did Swiss Air crash, have a very personal familiarity with tragedy and with the issues around the impact, the human impact of tragedy from that military world. But I also see it in terms of family violence. I see it in terms of street violence. I see it in terms of emergency providers. Been to an accident lately, guess what? And so one of my goals in putting this together was for us to perhaps get out of our organizational silos a little bit, get out of that comfort zone, meet some new friends and allies, and realize that you're not alone in having to deal with this. So let me just do a quick straw poll. The uniforms are pretty easy. Military, hands up. All right. Emergency services, police, fire, ambulance. Great. Nonprofits that deal with the Pandora, homeless. Great. Elder care. How about youth at risk? Yeah. And so, oh, I got a touch. Thank you, Padre. Faith community. The Sin Bosuns are here. Organizationally, very different. But the common theme is you care about this topic and the people that you're trying to take care of. Let me tap into one more. Families, spouses, and without putting you on the spot, how many of you are carrying the burden? Who's got PTSD? There you go. So a very eclectic mix. Folks who've seen it personally, folks who have friends, neighbors, and I come to this from the perspective of being concerned for my neighbors, my shipmates, the folks I've been on missions with, the folks that are in my neighborhood. Just working the homelessness gig, we recognize that if you achieve intervention, if you prevent issues from snowballing, it saves you money. More importantly, it saves you in lost human potential. One of the goals, of course, is being able to recognize, diagnose, get in front of it so you don't get through the depression, drugs, divorce, law and order. If you get out in front of that, and I think certainly the healers in the room will be able to give us some thoughts about that particular approach to life. The agenda today is very action-packed, so we'll get on with it. I am, in fact, still missing one of my first speakers, but we've, with Veterans Affairs, decided to do a bit of tap dancing around that. We start with an institutional look. Veterans Affairs and CF very much recognized as having issues right now, and particularly with Afghanistan coming to a close. What about that? Cockrell House, I'll mention, has had Korean War vets, Balkans vets, is now seeing their first Afghan vets. An Afghan vet homeless. Not a good thing. The issue there isn't that folks fell through cracks. We all recognize why folks fall through cracks, and I have personal experience with Veterans Affairs Canada. They took care of my dad in his last year of life. I know they're a compassionate, caring organization, but they can't catch everyone, and that's what the community is for, and that's part of today's conversation as well. So let me ask my friend from Veterans Affairs, Juan Cargnello, to come up, and we'll start the day podium, all right? Okay. And I'll bring up your display.
Yep.
There'll be some instances where we've got lots of room for questions, some with a little less room for questions, but the last session of the day, when we're looking at the trauma-informed community of care, will be where everyone will have a chance to say, how do I get some of this alliance? And what does that look like? So if you feel a little stilted during the day, I just ask you to be patient. We'll get there.
Good morning, everybody. My name is Juan Cargnello. I'm from another part of Canada, namely Montreal. It's a pleasure to be here. Very nice, very impressive university. The location is just spectacular and unbelievable, actually. I couldn't believe when I was turning with the taxi that we were actually approaching this little nook and small haven. I'm a consultant, psychology consultant with the Operational Stress Injury National Network. Been a professional psychologist for 32 years with the organization, VAC. And I have a lot of liberty this morning because my first presenter is not here, so I can elaborate a little bit on some of the things that I was probably going to be very terse with. And so maybe a little bit about my observations being a psychologist within Veteran Affairs, especially in the last remaining Veteran Affairs institution that is there today. Indeed, St. Anne's Hospital is the last remaining, and talk is that eventually we will be transferring that to the province, but that is not my expertise, nor can I elaborate on that. But my observations as a psychologist within Veteran Affairs, I have two. One is that, by the way, I'm one of the two last remaining psychologists from the 1970s, so I'm really dating myself, okay? In 1978, when I first started to work with Veteran Affairs, there were only 5 psychologists within Veteran Affairs throughout Canada. And there's 2 of those that still remain, and we seem to be holding on as best we can. And what I saw was, as a clinical psychologist, I saw the population changing, and I'm going to be referring a bit to what Roger mentioned when he was talking about his dad. I believe your dad was a veteran. I saw, when I first entered St. Anne's, young men, basically, you know, still young, in their 50s, maybe late 50s, that was the average age. 70s, 80s, 90s come about, and I noticed that population really began to age dramatically. And what we were dealing with at the time was chronic care for the elderly, and especially with problems related to cognitive deficiencies. At the same time as we saw that, or I observed that, I was also very lucky to see that there was another possibility to help the new veterans that were coming through. Because I recall in the late 90s and early 2000s, that's when our institution, St. Anne's Hospital, began to address this new veteran that was coming through that we could not help given the means that we had established up to that date. They were incongruent. They weren't transferable. The work that we were doing with our chronic care patients was not transferable to this newer population. And in my early years, I was very lucky to have in my later years, in the 1990s and year 2000, I see my colleague, who's supposed to be here, has just entered. But anyways, I'll take his spot, and I'll stay on and do my presentation, and he will continue with his presentation later. I was lucky to be, how would I say, acclimatized and maybe shaken a bit by some of the veterans, the newer veterans that were demanding attention and care from VAC. And I was part of that first wave of clinicians within VAC that we started to notice that need, and we started to address it in the early phases. So those are just my observations. That's my entrance into a bit of my background and work with the new veteran. Today we're talking about PTSD as a clearly diagnosable medical psychological condition. If you notice, we can go to the next slide. Next, that's it, yeah. If you notice, I have PTSD and then I have operational stress injury right beside it, because even though we are talking about PTSD, the nature of the problem is certainly more grandiose and far-reaching. So we in Veteran Affairs and I believe in National Defense, we use the term operational stress injury, which is a little bit more palatable, maybe as a term, because it doesn't scare people off as a disorder, maybe. And it's also a more inclusive term that refers to all possible psychological, persistent psychological problems associated with service. And under it, it's not a medical term, it's not a medical diagnosis, as most of you must know, but it does encompass some of the problems that we see, including PTSD, which are clearly definable, depression, anxiety, the addictions disorders, the chronic pain also that we find very, very prominent in that population, relationship problems, aggression, hostility, and so on and so forth. The gamut, the umbrella term serves as much better than staying with the term PTSD solely. So, as I said before, I work for the Operational Stress Injuries National Network. as a consultant there. Actually, we used to be called the National Center for Operational Stress Injury till January, and then we switched over. So some of you may know us as the National Center for Operational Stress Injury. We were, the center came into being in the early 2000s. I'm going to be replacing you for a while, you know. So we came into being in the year 2000 in response to having to create centers that would be able to treat and pick up some guidance as to where to go when it comes to treatment. We certainly follow the mental health strategy of Veteran Affairs, which, when it comes to OSIs, emphasizes that we should be aiming towards exemplary client-centered care for veterans, other clients and their families in view of service-related difficulties. Next. Through the last 10 years, the clinic network has added about, since the year 2001, 2002, we've added about a clinic a year. We now have 9 outpatient OSI clinics, operational fully, and we also have 1 residential treatment center. 8 of those are through MOUs with provincial health bodies themselves, and 2 remain part of Veteran Affairs, totally managed by Veteran Affairs, the clinic at St. Anne's Hospital and the residential clinic as well. The clinic network oversees and manages all components related to the operation, the assessment, the treatment, the outreach of OSIs in the clinics. There is a core commitment, which I'm really going to be elaborating a great deal. Maybe we can go to the next 2. Especially the last one, which is our core commitment to evidence-informed interventions. And I'll probably be expanding on that a bit. And clarifying it as I go through the presentation. We can go to the next slide. These are the clinics as they're situated right now. We have all 10 spread out throughout the country. 9 plus the 1 residential center. I guess I can also say that we should superimpose the joint network with the OTSSC clinics that also could be there also. There are 7 clinics. Perhaps Dr. Jetley will address to that, but anyways. They complement our, and we do work jointly with them. Just a few statistics for you. We have served 5,500 clients since the beginning. That's the numbers that we operate with. That does not include the inpatient clients that have gone through our residential clinic, which is 265 to date. So we're upwards of almost 6,000. There's currently 2,089 active client files in our clinics. We've served 2,981 clients since April 1st, 2001 to February, which is an increase of about 30% in our client base. For 2012, it is estimated that more than 3,000 clients will have been served. Again, an increase. This year, we've also have treated or have received 1,300 new clients compared to 989 for the previous 12 months. And that also represents a 34% increase. So you can really see that there is an upward trend here in terms of the clients that we are engaged with. Our clinic network has about we can go through the statistics. Sorry, I read them out here. That's what happens when you don't have control over the PowerPoint, I guess. But this is good. We have about 100 staff members, which comprises of...
Should be left click.
Okay. As I started to say, that we have about 100 staff at the clinics, which comprises of psychiatrists, psychologists, social worker, nurses, and other mental health professionals. Next. You said left? Yeah.
Left click should work. Well, right, try the left click.
Okay. Working. Go to the next.
Okay, just use this one.
I'll address some of our technological challenges. Are always interesting when you're up at the podium, you know. I'll talk about some of our initiatives right now. One of them is the family services. We've seen an increase of about 41% response to family needs in the last 12 months at the clinics, whether it is through education, through psychoeducation, whether it is through counseling, conjointly. What happened is that the clinics had different approaches depending on where they were and what resources they each had. The clinic network manager decided to establish clear guidelines for the OSI clinics, how to proceed when it comes to issues related to family concerns. And we all know how important engaging the family is. It is such a vital element in terms of recovery and improving the lives of individuals who have OSIs. If you neglect that, it becomes an issue for sure. And so we targeted that, and we addressed it by having two sets of studies. The first one was certainly how to best respond to the need. And the second one was how to implement that. I know there's a set of recommendations that came, 7 set of recommendations that addressed what type of best approach would be for each clinic to adopt. One of them is to have a champion who would represent the need for family services, improve family services within each clinic, and at the same time to unveil evidence-based informed treatments that incorporate families. I won't detail the 4 different approaches that are being they are being enacted right now. But I already know that, for instance, there is at least 2 or 3 clinicians that are being certified in family treatment using cognitive behavior approaches. And their expertise will obviously be disseminated throughout the clinics, hopefully. Another project, initiative that's very, very important is the outcome measurement, the CROMIS, which is the Client Reported Outcome Measurement Information System. My colleague Dave Ross is spearheading that, which will be a computerized system of evaluating how it's going in terms of whatever treatment individuals are receiving. And the best way to check that is to have an index, to have a matrix. And this system here will provide that matrix. It uses some standardized measures that are really very reliable in the field. The OQ45, some of you may know it, and I know some of the clinics are already doing in paper form. We are trying to adopt a more of a computer system that will assist with that. We're just having it translated, actually. And I would say that this system is already in operation in the American forces and other organizations quite successfully. There is the chronic pain management initiative as well. That's an initiative that, again, came out of a growing concern from the clinics who were reporting that a lot of their clients have conditions that do require attention and intervention related to pain. What we did, which was, again, we used a sort of a methodology or a system of obtaining information that's reliable as we can. We approached McGill University, some experts within that institution that gave us guidance in terms of what are the best approaches, what are the best techniques to use to deal with pain in individuals with pain in OSI. And needless to say that I believe some of the numbers quoted is that the prevalence rate of pain in OSI or PTSD is anywhere from 40 to 70%. So you could see that it's a major need. The report just came out in March. I was given a copy of the report. There will be a follow-up by the coordinator of the clinical aspects of the clinics, and he will be unveiling some of the best practices known as were delineated in the report to address that need. Telemental Health is another initiative, and that's not, needless to say, that's not the same from clinic to clinic. It can vary a great deal relating to resources. But I can say comfortably that about 10% of all new clients do engage in telemental health with the clinics. About 10% of all new clients do that, whether it's in the assessment or follow-up phases, which you could see is very beneficial for those in the remote areas and those individuals that are really would be very inconvenienced to come in. If telemental health does assist and provide a means of reaching out, it's an ideal forum. There have been some good studies that looked at the reliability of the delivery of services with telemental health, especially in the United States. The evidence seems rather promising, so we're following up with that. And the last one, the last bullet, is something that I'll expand upon, which is the support for the dissemination of evidence-based treatment and best practices. And that is a commitment that we've taken on, and I think we're joined by national defense at the same time. And that is where a lot of people are going this way, both nationally and internationally. Most bodies of knowledge are going towards that means, towards that ends. Next slide, please. And I'm not trying to be facetious here, but by the way, I'm not trying to be selective either, okay, in terms of just putting down some of the therapies that are out there, some of the treatment approaches. Last count, and again, this is, it's not, how would I say, very, very, it may not be particularly accurate, but I've heard of numbers up to 270 different techniques, approaches, treatments, and a lot of them are out there. Unfortunately, and I say this seriously, only about 5%, close to 5%, do outcomes, actually do look at what am I doing, you know, with the clients. And so those are important issues that we have to address. And that's why we feel that we have to be committed to evidence-based practice and really basing our focus on that concentration. Next, why do we support it? The goal is to optimize client outcomes. It's always client outcomes. And the only way you can check client outcomes is if you actually do it. You know, it is not just enough to say that someone looks better, but you have to have some data that also backs you up in order to complement that. And a goal is also to provide high-quality treatment that's supported by standardized and reliable sources of knowledge as well. The basic rationale is research findings are often abundant. They're all over the place. At times they're contradictory. So you need to integrate all this vast amount of research. And we certainly do not have the manpower nor the ability to do that. What we do is we look at sources of knowledge, of expertise. Can I have the next slide? Yeah. And those are some of the international and national bodies that we have based our follow-up in terms of our commitment. There's the National Institute. And if you can see, actually, most of the evidence or the best practices surrounds general population and military veterans. So we can look at both, okay, and compare both sometimes also. So you have the National Institute for Health and Clinical Excellence, which is the, in Britain, the International Society for Traumatic Stress, an international body, the American Psychiatric Association, and this is just to name a few. Military veterans, we have the D&D and VA reports that have come out, 2010. By the way, the best practices report that was issued in 2010 is more for policies and planning, but nonetheless, there's a fair amount of good, reliable information that can be extrapolated from that. The Australian Centre for PTSD with leader Dr. Kramer and Dr. Forbes. And the IOM, the Institute of Medicine, which was also asked by the American VA, DOD to provide guidance in terms of how do we choose amongst this vast array of, this plethora of approaches, you know. And we rely on their ability to as I said, to extrapolate the best treatment approaches, those that are reliable, those that are scientific, and very valid. Next slide, please. How are they developed, these best practices? Well, who's the intended audience? Is it, if it is psychiatrists, you know, like I have a few in the audience, it's going to address a different conclusion than if it is a multidisciplinary group, you know. And how are they developed? Well, there's usually a systematic review of all the empirical findings. There's a procedure that they establish in terms of how do they go down the line in terms of looking at each study, what is the strength in the study, how do you value that study? And the bottom line is to make recommendations. Okay, and usually these bodies of sources of information, of best practices, do provide that. And next slide, by the way, too. There's a caveat, and I throw that in because there's not enough research still, and to drive all the recommendations in the guidelines sometimes. It is sometimes disorder specific, sometimes. I noticed in the last few years a lot of research studies are addressing this and being a little bit more inclusive and including, for instance, how selective are you with the population that you're treating, how are you choosing them? And therefore, if you're choosing in an extremely strict, limited way, you can get limited results. But it doesn't mean that it's true to the population at large who have those problems. So we do see that this is being addressed. And as I put up there, in the clinical world, comorbidity seems to be the rule rather than the exception, There's certainly an influence of publication. What gets published, gets published. So therefore, it circulates, The bottom line is, though, if you do have a treatment approach, and if it works, you should be able to publish it. You should be able to have your peers review it in order to say, this makes sense. Because if your peers say that it may not, you may have to go back and rethink things. Often, by the way, these documents are so long and they're very hard to apply at the same time. And therefore, executive directives are usually the way to go rather than these huge documents that sometimes, by the time you've read them, you get lost and confused. Next. General findings. Trauma-focused therapies are the way to go. They work. And I have listed there trauma-focused CBT for PTSD, prolonged exposure, cognitive processing therapy, EMDR, is recommended cautiously because some of the data seems to indicate that the saccadic eye movement may not be an essential component in the treatment itself. But anyways, these are the conclusions today. These are not the conclusions tomorrow. I'm saying that because right now, even in the National Institute of Mental Health in the United States is sponsoring at least 12 studies that I know, maybe more than that, in terms of great RTC, very rigid randomized controlled trial studies that are incorporating a newer set of treatment approaches, which is really interesting. Now, it takes years for these findings to be published, but I'm sure that's going to weigh in, and we're going to see if they succeed to prove that they are efficacious, reliable, and standardized procedures, that they will be added to this list. By the way, the Australian Centre for PTSD is about to rewrite their best practices and evidence-based practices report. It should be coming out in about 6 months. So even they are constantly reviewing what seems to work. Okay? But it has to be based on empirically proven treatment methods. Next slide. Thank you. So how do we transfer? And this is something that is a challenge for everybody. How do we transfer empirically supported treatments into practice? Despite the evidence of empirically supported treatments, clinicians tend to be low in terms of utilizing, incorporating these treatments into their practice. There are certain barriers, perhaps beliefs, attitudes, habits. There may be a knowledge gap also. There certainly is a knowledge, a dissemination problem in existence. That is to say, how does that information transfer out? And usually, and I can speak certainly for my profession and most likely psychiatrists, is that we have these workshop approaches where you have these brilliant individuals that come up and give you a treatment approach, a one-day workshop, you walk away, and you're supposed to be able to implement it. It's very unlikely. That didactic approach does not work that easily. So there are dissemination practices, suggestions that are out there, and we are incorporating that within our clinic network when we are disseminating the best treatment approaches to working with individuals with OSIs. It incorporates didactic with follow-up, with support, with consultation, with supervision, and then after that follow-up, and most likely even some kind of certification or meeting some standards that you can apply the treatment technique. So we can go to the next slide. When it comes to optimizing client outcomes through dissemination, we do it two ways. We've done it two ways at our network. One is certainly for the systematic review of evidence-based practices and to develop best practice guidelines. That was done internally. It was done internally, as I showed you before, because we wanted to make sure that we were in keeping with what was out there in the bigger picture, in the rest of the world. And certainly we feel confident that we are. Step two now is how do we disseminate that further onto our own clinicians? And the network has done it so far twice. With a prolonged exposure training that was issued in 2011 with, I believe, about 23 participants. Half of those were doing individual supervision with the originator, actually, of prolonged exposure, the expert driver in the world of prolonged exposure, Edna Foa. She was coordinating the consultation of the learning that was occurring in our clinicians. I believe 8 of those of the trained will be certified and have been certified. Have been certified as prolonged exposure providers who can themselves supervise other colleagues. So there's a bit of a dissemination there. Hopefully that information will transfer amongst the clinicians. Another project has been the cognitive processing therapy by our group with, in conjunction with Ryerson University. We've just embarked upon that. It is Dr. Munson at Ryerson that is a world-renowned expert in cognitive processing therapy. And what we have done, one of my colleagues actually, he's partnered with her and have applied for a dissemination grant from the CIHR, the Canadian Institute for Health Research. It's a dissemination grant. It's I think it's worth about $350,000 all in all. And what that grant allowed us to do is to set up a national training forum, which we just came back from in March. It was in Toronto. We had about 120 service providers. There were about 60 from the clinics themselves. We were joined by several from National Defense, and about 50 from the private sector service providers, which, as you know, VAC relies a great deal on. So we were really happy to bring them on board. The training was actually free. And there was even some, due to the grant, we even had some built-in incentives in terms of travel costs, and that's what you have to do sometimes. You have to do that in order to make it palatable for people to be interesting. So we've done the training. Now what we're doing, because again, we're following an evidence-based model, is that we're actually checking what is the level of knowledge of these individuals. And the way we're doing that is to follow up with a study. This randomized control study with 3 groups. One set of individuals will receive individual supervision over the phone. Another set of individuals will receive group supervision. And another group of individuals will not have the supervision, but will be evaluated at some point in time to see how they compare to those that have received the training. Looking forward to the results. It's supposed to start very soon, depending on how easily where the clinicians are working and can accept all the demands for ethics and control. But we're about to embark on that. So we're quite pleased with that, and we should see results. Unfortunately, with research, it always takes a long time. We'll probably only start to see the first set of results next year. But that knowledge transfer should mean better care. That's what that is supposed, the trickle-down effect of the better treatment, the more knowledge, the more it trickles down to the clients and families. Next slide. So, some considerations when implementing psychotherapy best practices and PTSD, things that you have to consider. Patient issues. Is the client, does he have or she have a preference? That is to be considered. Sometimes our approaches may be very good, but we have to tweak them a bit in order to meet that particularity of the client. Is the client able to engage or not? There are provider issues. Can the provider really, is he capable of stimulating engagement in the client? You know, how capable is he or she? And what is the fidelity to treatment also? It's interesting to say that, well, you know, I could say this, I was trained as a psychoanalyst 32 years ago. But has anybody checked whether I was actually doing that sort of particular type of therapy properly? There was no fidelity check. People were given the titles and you went out there and you worked, you know. So fidelity is another issue that's quite key in the area of dissemination of practices and treatment approaches. And there's also systemic issues, availability and cost for sure. Some treatments are certainly much more costly than others. And so how do you weigh those, you know? Next. Well, this is a little bit of a muddled one. I guess the message here is how complex the issue of OSI is, you see. It's not just one domain. It's not just PTSD. It's not just depression. It's many, many. And sometimes they occur conjointly, as I said. The comorbidity is certainly more prevalent than not. And at the same time, if you're targeting one of these areas early on in the initiation phase with, let's say, PTSD, how do you handle the other domains, you know? It's a very, very difficult juggling procedure. And that requires a great deal of skill, and hopefully with time we'll be able to elaborate on this. Next. Oh, there should be another one before. No, there isn't. Okay, then I'll share with you my notes that I have here. Sorry. Another initiative that I'm involved in through the network is one on peer support. From the year 2001, I've been involved with sort of consulting and knowing that peer support is certainly a best practice. It's very well documented. The problem is we say it is a best practice. In terms of the evidence, we don't have objective evidence, empirical evidence. However, in the last 2 years, I'm glad to say that we're starting to see the first trails of research that address the applicability of peer support and how efficacious it can be. There was one study 2 years ago in Norway using peer support with psychotic outpatients, and that was an RCT study that proved that it managed to have success, very, very well measurable success. There is another study that was done in Montreal at the Allen Memorial last year, published in the Journal of Mental Health, I think. Yes, and she again used a randomized controlled trial study to look at the effects of peer support as an adjunct to traditional treatment. She also found some positive findings, quite reliable. There was a meta-analysis, which is another way that's professionals look at data, where you can pool data from many different sources to see whether there's a reliable source of success in what they're doing or not. And this was done in the States. It was published, I believe, in November last year. And it looked at peer support for individuals that suffer from depression. Of course, it's a sister group, not PTSD per se. And again, it showed it was quite efficacious. And so all these are promising. I think when it comes to peer support, it's going to be very, very hard to apply the measures and the system of analysis that we have right now for clinical studies, because in effect, we're looking at a phenomena that perhaps doesn't follow the clinical picture per se. We're dealing more with social support, and we may have to tweak how we operationalize success and what sort of measures we incorporate in studying. But it is coming. Peer support is a new wave, and certainly I'm sure a lot of you know about it. Anyways, I've been engaged with, in my capacity as a psychologist, and I'm dedicated to best practices. What I've done is that I've amassed best practices training for peer support, individuals that are willing to partake in peer support. I do it in 3 capacities. I do it for the OSIS organization, which is a partnership between Veteran Affairs and D&D. And I'm glad to see that there's some faces from OSIS here for sure. And I do that. The other one is that I also work with the casualty CDSN, no, the DCSN, the Director of Casualty and Management. Support Management, yes, who in the JPSU unit also has an interesting peer support component, which is the HOPE program, helping others to promote empathy, which is basically a peer support program for those that are in bereavement, those that have lost somebody in service. I incorporate best practices in terms of the training that I provide those individuals that are involved at that level. And the last level of involvement that I have with the peer component of mental health, which is still new, I'd say, and we have to speak about that with caution in terms of the what we have in terms of objective data. But the last one that I'm involved with is with the Mental Health Commission of Canada, the peer project there that's spearheaded by Stéphane Grenier. He's actually establishing national standards for competency, core competencies for peer providers, peer support providers. And I've been involved from the very get-go with that. And at the same time, in the process of disseminating best practice treatment for peer initiatives throughout Canada with Mental Health Commission, and I hope to continue doing that. It seems to be promising. So now I'm ready for my last key messages. And I saw I'm on track. So, final key messages is Operational Stress Injuries National Network is committed to evidence-informed interventions at all costs. We promote that, we follow that, and we espouse that. I know that our national defense is also very much on board when it comes to that. Operational Stress Injuries National Network is prepared to meet the challenge in support of outcome measurements, and that is our way of saying we are going to try and make sure that we obtain good, quality, reliable, standardized measures of success or not in order to see whether what we're doing makes sense. The only way we can do that is to check outcomes, always. Veterans and other clients and their families stand to benefit the most from EBP, evidence-based practice and outcome management. I have no doubt. With that, I'm going to end my discussion. I think are we okay with time?
Great one. Ladies and gentlemen, our next panelist is Colonel Rakesh Jetley. We're just going to do a quick technological change and put his laptop online, so a 30-second pause in place. Rakesh,